Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. As we was talking about chemotherapeutic agents, and today our topic of discussion is antimicrobacterial drugs, those drugs which are used for the treatment of tuberculosis. So let's talk about our point. We begin from the rifampicin, and the point here is that rifampicin causes damage to the contact lens urine discoloration, and it causes red urine. It causes orange coloration of contact lens, and it is taken before meal, and it's taken with the isoniazide decreases bacterial resistance. So the main point here is that it causes discoloration of contact lens, urine, as well as sweat. And next point is about the isoniazide. Isoniazide causes peripheral neuritis and due to INH induced pyridoxine deficiency. It is the most potent anti-TB drug. It is metabolized by the acetylators and it causes lactic acidosis and peripheral neuritis. This peripheral neuritis is managed by the use of vitamin B6. So this was the point about isoniazide. And one thing keep in mind that slow acid dilator develop a rapid neutropathy with the isoniazide. So this point must be kept in mind. That next is about Mintox test and tuberculin test, which is used for the diagnosis of TB. Rifampicin and phenobarbital. These both are liver metabolic enzyme inducers. So here is the room for drug interaction. Next point is about the isoniazide rifampicin, used for 9 months, and it is enough to cure 95 to 98% of cases of tuberculosis. And intensive phase is recommended for 2 months due to prevalence of resistance, and pyrazinamide addition during intensive phase allow total duration of therapy to be reduced to 6 months. Fourth drug, that is the ethanbutal. Drug provide additional coverage, and if isolate prove to be resistant, if isolate is proved to be or microbe is proved to be resistant, then fourth drug is provide additional coverage. So ethanbutal doesn't need to be added if therapy is initiated after isolate is known to be susceptible to isoniazide. So then only three drugs would be enough. But if isolate is resistant, then fourth drug will provide additional coverage. So here are some examples of antimicrobial drugs used for the treatment of TB and their doses. So I will mention them. So we divide them into two lines, that is the first line treatment plan and second line agent. First line agents and second line agents. Isoniazide include isoniazide, rifampicin, pyrazinamide, and ethanbutal included in first line agents. So let's talk about the doses. Isoniazide is recommended with a dose of 300 mg per day, and rifampicin is recommended with a dose of 600 mg per day, and pyrazinamide is recommended with a dose of 25 mg per day, and 25 mg per kg per day. Pyrazinamide is recommended with a dose of 25 mg per kg per day, and ethanbutal is recommended with a dose of 15 to 25 mg per kg per day. These are the first line agent for the management of TB. Second line agents. Amikacin. Amikacin is recommended with a dose of 15 mg per kg per day. Aminosalicylic acid is recommended with a dose of 8 to 12 gram per day, and bedaquiline is recommended with a dose of 400 mg per day, and capreomycin is recommended with a dose of 15 mg per kg per day, and clofazimine is recommended with a dose of 200 mg per day, and cycloserine is recommended with a dose of 500 mg to 1000 mg per day. It can be divided according to demand. Ethionamide is recommended with a dose of 500 to 750 mg per day, and levofloxacin is recommended with a dose of 500 to 750 mg per day, and linezolid is recommended with a dose of 600 mg per day, and moxifloxacin is recommended with a dose of 400 mg per day, and rifabutin is recommended with a dose of 300 mg per day, and rifapentine is recommended with a dose of 600 mg once weekly. 600 mg once weekly would be enough. Streptomycin is recommended with a dose of 15 mg per kg per day, and these are recommended. Streptomycin is recommended through the intramuscular and intravenous route. So these are the drug which is used for the management of TB and their doses. Keep in your mind that isoniazide inhibits the liver metabolic enzyme, but once it is used in combination with the rifampicin, it induces overall effect would be induction, you can say, because as you know that rifampicin is a strong inducer. So isoniazid and rifampicin, when these both are used in a combination, then they both act as an liver metabolic enzyme inducers. Irrespective of this, that isoniazid is an inhibitor. Overall effect would be liver metabolic enzyme induction. So this is a point. So no, these are the almost all important point which is relevant to the exam. So no, we will talk about the summary of drug that is used, drugs and their toxicity that is used for the management of tuberculosis. So as long as you know isoniazid is concerned, its clinical application is it is a first line agent for the tuberculosis and treatment of latent infection and is less active against non-tuberculotic mycobacterial agents. Isoniazid is less active against non-tuberculosis mycobacteria. It is given. It is dose route of administration is oral and IV, and its toxicity is hepatotoxic, peripheral nephropathy, and given pyridoxine to prevent this toxicity. But its toxic peripheral nephropathy, and hepatotoxicity is these are the two side effects associated with isoniazid. Next is about rifamycin. In this drug include rifampicin, rifabutine, rifapentine. Its clinical application is it is a first-line agent for the tuberculosis and non-tuberculotic mycobacterial infection and eradication of non-meningococcal colonization and streptococcal infection. These are its therapeutic coverage. It is also used through oral and intravenous route, and its toxicity include rashes, nephritis, thrombocytopenia, cholestatic flu-like symptom with intermittent dosing. These are some its toxicity. Next is about the pyrazinamide. Pyrazinamide is also known as sterilizing agent and is used during first 2 months of therapy and allow total duration of therapy to be reduced for 6 months. It is administered only through oral route and its toxicity include hepatotoxic and hyperuricemia. Lastly, the drug is ethanbutol, and its clinical application is that it gives given in fourth give in for during initial combination of therapy for tuberculosis until drug sensitivity is known, and also used for the non-tuberculotic mycobacterial infection. As if drug sensitivity is known, then its administration will be decided, but it provides an additional coverage as I have already told you in previous points. Its route of administration is oral, and its toxicity include retrobulbar neuritis. Main thing is that retrobulbar neuritis is toxicity of ethanbutol. So these are all points relevant to the antimicrobial drugs. About antifungal drug and those drugs which is used to manage the fungal infection. So let's talk about our point. Tolnaftate is a antifungal drug. It is ineffective against candidiasis, keratolytics, and astringents. Keratolytics is also known as anti-inflammatory. So tolnaftate is ineffective against candidiasis, keratolytics, and astringents. Thrush is also known as oral fungal infection. It is also named as candidiasis, but it is defined for the oral fungal infection. Side effect of ketoconazole is gynecomastia, hepatotoxicity. Nystatin is used for the treatment of candida, and it is also drug of choice for monaliasis. And the dosage form of nystatin is cream. Ketoconazole and cresofulvin has different dosage form, but cresofulvin is we'll talk about these two drugs dosage form in later points. But main point is that nystatin is used in through topically. It has no any oral dosage form. Nystatin is also used for the treatment of Candida albicans, which is also known as monaliasis. A repetition of previous point. Glycofulvin is used for the tiny tinea capitis. Tinea capitis is a type of fungal infection against which glycofulvin is used. Side effect of ketoconazole is gastrointestinal disturbance, headache, gynecomastia. Ketoconazole need acidic medium to be active, and thus it is contraindicated with famotidine, which decreases the HCl or acidic environment. Ketoconazole is only oral antifungal drugs, and amphotericin B is a topical injectable form. Ketoconazole is contraindicated with the antacid H2 blockers per proton pump inhibitors, C-capride, C-cis sorry, C saparides and food and amphotericin B. These are the drugs with which ketoconazole is contraindicated. Ketoconazole and estamizole are which is also known as terbinafine. These two produces life-threatening reaction and it interact with the warfarin. Glycofulvine is taken after food and it is prepared in microcrystalline form to increase solubility and absorption. It is liver metabolic enzyme inducer, so interact with the oral contraceptive. It is not used topically. Racefulvine is an and nitrofurantoin are given after meal, but penicillin and tetracycline are given before meal. Clotrimazole and statin are used for the treatment of candidiasis. And the next point is about amphotericin B. Amphotericin B, its effects on kidney. Amphotericin B causes acute kidney injury, creates pores, and compromises membrane integrity and increase the membrane permeability. So it adds its effect in acute kidney injury. Ketoconazole effect on skin, irritability and reddish skin. These are two effects caused by ketoconazole on skin, cause irritable and reddish on skin. And miconazole is also an antifungal drug, bacterial vaginosis treatment. It is treated by the use of clindamycin cream, metronidazole cream, and metronidazole oral dosage form. So these are in combination used for the treatment of bacterial vaginosis. Amphotericin B exploit the difference between the composition of lipid of fungal and membrane and cell membrane. The main point is that amphotericin B exploit the difference between composition of lipid of fungal and mammalian cell membrane. This is the mode of action of amphotericin B. Its dose is 0.5 to 1 mg per kg per day through slow IV infusion, and it is excreted through renal. It causes side effect is renal impairment and nephrotoxicity. Azoles examples are clotrimazole, miconazole, voriconazole, itraconazole, fluconazole, ketoconazole. It is effective against candida and neoformines and endemic mycosis. Its examples are blastomycin, can the coccidiomycosis, which we'll talk about later on, and histoplasmosis. These are comes under the endemic mycosis and aspergillus. These are the fungal infection microbes against which azoles are used. And azoles examples are clotrimazole, miconazole, voriconazole, itraconazole, fluconazole, and ketoconazoles. These are the examples of azoles. So next is about the itraconazole. It is used through IV route. Its dose is 100 to 400 mg per day, and fluconazole is used through oral. Its dosage form is for oral and IV route, and its dose is 100 to 800 mg per day. Azole, it's also known as azole of choice, and in the treatment of secondary prophylaxis of cryptococcal meningitis, and IV is considered to be equal to amphotericin B in the treatment of candidemia in ICU patient with normal white blood cell count. So if it's a comparison with amphotericin B in ICU patient with normal white blood cell count in the treatment of candidemia, commonly form of mucocutaneous candidiasis. It's a commonly form of mucocutaneous candidiasis, but it has no activity against aspergillus and filamentous fungi. This fluconazole has no any action against aspergillus filamentous fungi. This was all point relevant to the fluconazole, which is a azole of choice, commonly available in therapeutic pharmaceutical preparation form. Prophylaxis in the bone marrow transplant and AIDS. These are also implication of fluconazole. Voriconazole. Next one is voriconazole. Voriconazole is also its dose is 400 mg per day. It's used through IV and oral route, and posiconazole is only liquid formulation. Its dose is 800 mg per day in 2 to 4 dosage form doses. Glycofulvine is microcrystalline oral form. Its dose is 1 gram per day, and duration is 2 to 6 weeks for skin and hair infection. Nail therapy required treatment for months to allow regrowth of new protected nail. Terbinafine, its dose is 250 mg per day orally, and it is used for the treatment of dermatophytes, especially onychomycosis. Terbinafine 250 mg per day oral dose for 12 weeks cures 90% rate. Cure rate is 90% for the treat for the onychomycosis. This is all about the terbinafine. Nystatin, skin mucous membrane candidiasis apps. So this point is about this nystatin, which is used for the topically, and it's used against mucosis membranous and candidiasis apps. Mucous membrane and candidiasis apps fungal infection is managed by the use of nystatin. This is the point here which I want to tell you. Clotrimazole and miconazole topically used for the vulvovaginal candidiasis. These are the therapeutic implication of clotrimazole and miconazole, which is used against the vulvovaginal and vulvovaginal candidiasis fungal infection. This is the type of infection which is known as vulvovaginal candidiasis. It is treated by the use of clotrimazole and miconazole. So this is all about the point relevant to antifungal infection. Now we will talk about the summary and conclude this chapter. As long as amphotericin B is concerned, it is used for the treatment of localized systemic candidiasis, cryptococcus, histoplasmosis, blastomycosis, and coccidioides and aspergillus. These are the infection and fungal infection which is covered by the use of amphotericin B. Its oral form is not absorbed, so IV form or systemic route of administration is used. Its toxicity is infusion reaction. As it is used through IV route, so its toxicity is infusion reaction, renal impairment, interaction with additive with oral or renal toxic drug. If there is a other renal toxic drug used in combination with amphotericin B, it has an additive renal effect or toxicity. Lipid formulation, lower toxicity and higher dose can be used. It's lipid formulation with lower toxicity and higher dose can be used. So this was all about amphotericin B. Next is about the flucytosine. Flucytosine, it is also antifungal drug. So it is used for the cryptococcus and chemoblastomycosis infections, that is used. Its toxicity is myelosuppression. Next is about the azole, that is the ketoconazole. It is a broad spectrum toxicity resistant use to topical therapy. It is a broad spectrum but toxicity restricted. Its use topical therapy. Its toxicity restricts its topical application. So it is used through oral and topical application, and its toxicity is interfere with the steroid hormonal synthesis and phase 1 drug metabolism. These are its toxicity of ketoconazole. And next is about the itraconazole. Itraconazole is a broad spectrum. It is used against candidiasis, cryptococcus, blastomycosis, and coccidioidomycosis and histoplasmosis. These are the microbes which is covered by the use of itraconazole. It has low toxicity. Its formulation is oral and IV. Its other examples, as I have already told you in previous point, that is I have already informed you in previous point, that is the fluconazole, voriconazole, posiconazole, or itraconazole flu, and these are the examples. So next point is about the caspofungi. Caspofungi is used for the fungicidal candidiasis apps and also used in aspergillosis or aspergillus infection, that is known as aspergillosis. Caspofungi is used for its treatment. It is used only through intravenous route, and interaction increase cyclosporin level. It increases the cyclosporin level. Here is its interaction. And last point is about the terbinafine. Terbinafine is used for mucocutaneous fungal infection, and its toxicity is used through the oral route, and its toxicity is gastrointestinal upset, headache, hepatotoxic interaction, and non-interactions. And as long as interaction is concerned, it don't have any interaction. So its toxicity is gastrointestinal upset, headache, and hepatotoxicity. So these were the points. I